Hello, everyone, and thank you so much for the opportunity to present. I'm going to be presenting on our project, the Association of Profit Status and Trauma Center Designation with Racial and Ethnic Diversity and ED Transfers. So to begin, health equity has really become at the forefront of the conversation of healthcare delivery, and concerns have arisen that for-profit burn centers without trauma center status may be cherry-picking admissions and selecting for commercial payers. This may also lead to these centers caring for fewer minority patients. And so in order to get an understanding of this, we need to evaluate the profit status and trauma center designation in relation to the diversity of burn patients treated. As for our hypothesis, we assumed that nonprofit centers will care for more minority patients and more Medi-Cal patients and uninsured patients than for-profit centers. So to carry out our study, we used the California Department of Healthcare Access and Information Database, which is a comprehensive database from the state of California, and we identified all inpatient encounters at verified and unverified burn centers from the years 2009 to 2019. Our primary outcomes of interest were the proportion of burn transfers accepted with Medi-Cal or uninsured. Notably, this is burn transfers to ED, not burn admissions, as well as the proportion of Black and Hispanic patients treated. Our testing variables were safety net status, profit status, ABA verification status, ACS level 1 trauma center designation, and our covariates included burn size, gender, age, and payer type. We performed descriptive statistics of transfer patterns with insurance status, as well as linear regression modeling with a proportion of Black and Hispanic patients as linear outcome. Analysis was conducted at the level of individual burn centers per year, with 12 burn centers over 11 years, which is the equivalent of 132 burn center years. And we applied Bonferroni adjustments for multiple testing. In Figure 1, you can see that there were more Medi-Cal and uninsured transfers to nonprofit burn centers. Markedly, there were only 2 Medi-Cal transfers to for-profit centers versus 239 to nonprofit centers. In Figure 2, you can see a widespread across different burn centers for the percentage of Black and Hispanic patients that each center took care of. You see around 20% all the way up to over 60, over 50%. And then in Figure 3, you can see that the percentage of Medi-Cal patients by burn center also varied by center. And notably, we're not allowed to disclose the specific burn centers due to restrictions, identity restrictions from the Department of Healthcare Access and Information Database. As for our multivariable analysis, we found that for-profit burn centers were negatively associated with the proportion of Black and Hispanic patients treated, and burn centers with trauma center designation were positively associated with a higher proportion of Black and Hispanic patients treated. We also saw that safety net burn centers cared for significantly more Medi-Cal patients, and verification status did not show a significant relationship. So all in all, we see that for-profit burn centers are caring for disproportionately fewer Black and Hispanic patients, and burn centers with trauma center designation care for more of these patients. We saw that for-profit burn centers have disproportionately fewer transfers with Medi-Cal as payer or uninsured compared to other burn centers, and disparities related to profit status and trauma center designation in burn centers really underscore a need for targeted equity-based interventions and policy development. As for our future directions, we'd like to investigate the transfer patterns of for-profit and nonprofit centers for Medicare and private insurance. We're going to include tables for the paper with regressions for both Black and Hispanic as outcome and Medi-Cal as outcome. And we'd also like to look more into location as a biasing effect for where patients are located in relation to burn centers. So maybe some geospatial mapping there. Also, our data raises questions about if there may be an issue with EMTALA and we'd like to investigate transfer patterns further to assess if this may be the case. Thank you so much for your attention.